So today's topic will be some of the complications that we can encounter during anesthesia and how to troubleshoot. So what are the complications? It's a very broad term, and it could be as a result of mistakes that we make, and examples could be filling the vaporizer with the wrong inhalant, filling syringes with the wrong drug, or mislabeling, and getting the decimal point wrong, which could either go both ways, I guess, 10 times overdose or 10 times less, in which case, obviously, the drug will not provide the intended drug effect. One of the consequences will be poor pain control when you misjudge the drug. Most of the time, you probably still haven't figured that you made a mistake in decimal point in those underdose situation. And the point that I'm trying to make is that sometimes you might be lucky enough to catch it, because the animal either does not show intended drug effect, and then you can go back to the calculation sheet and pick up that mistake. But not all the time you have that ability to do that. Some drugs are somewhat more challenging to really pick up that sign. The drug was either underdosed by 10 or whatever, in which case I would consider that's also a complication in a way that the animal in the long term will not have the desired benefit from the drug. Yeah, and the equipment failure, those are some example would be closing the pop-off valve and then you forgot to open it, and then the animal will have a pulmonary barotrauma as a result of that. Could lead to fatal outcome if the patient suffers severe extent of the barotrauma. So these human errors do happen, but we can structure our system to prevent those human errors as best as we can. Obviously, your alertness is very important, but also you can have a body check system where drug calculations are always checked by a second person. So death would be obviously the ultimate end point. Hypoxia and high heart rate, low heart rate, generally low blood pressure rather than high blood pressure, and cardiac dysrhythmias, and anesthetic depth being inadequate, either too light or too deep, allergic reaction, which fortunately rather are very rare for us to see that anaphylactic reaction. So anticipating complication is very critical for us to address. We will have a systematic approach about different complications, how we will troubleshoot them. These are some of the supplies and equipment that would be critical to save life. And here you have LifePak 10 physio control defibrillator on the top left. This defibrillator can also work as monitor, ECG monitor. It can have a pulse oximeter, capnograph, and all that. But generally, it's not really substitute for the multi-parameter anesthetic monitor, but rather this is used as a defibrillator and the monitor that will be utilized while the animal is being resuscitated. The other picture there are ambubex you are seeing, and pressure infusion bag. That's a useful device when you administer shock volume fluid for crystalloids. Obviously, you're not going to need to have a pressure infusion bag when you administer colloids because that they are small volume, but crystalloids, you have to administer large volume in the resuscitation phase. So you would be needing those as a useful device so that you can administer large amount of the fluid in a short span of time. And very neat arrangement of life-saving drugs. You see all different drugs there, and generally these are drugs that you would utilize to correct bradycardia, hypotension, and even cardiac arrest. It is important that you anticipate what drugs will be utilized to effectively address those complications. So it's important that you think through it and then stock with the non-expired item. The problem with this crash cart drawer and then drugs that are placed in there, because we don't end up using them a lot. And yeah, if you end up using them a lot, then you have a big problem. You got a big problem there. You shouldn't really use these drugs. If anything, not at all. But that's not possible. You're going to run into problem at some point. But what I mean by checking on the expiration date of the drug is because you don't end up using a lot, and then sometimes you will encounter a situation that you forgot to check the expiration, and then the state veterinary board sends their inspectors, periodically, randomly, unexpectedly, and then you may get cited. So something that you need to be careful. All right, so there's nothing to expire in this tray here. It's just different size of assorted endotracheal tube, blade, laryngeal blades, other gauze ties and gauze pad, hypodermic needles, catheters, syringes, tape. So you get the picture here. It's just basically something that you are going to need to draw blood, catheter. Different fluid types is also useful. You have crystalloids and colloids there. Obviously, colloids are way more expensive to stock, but it is very useful in volume expansion when you don't have a pressure infusion bag or infusion pump, and the patient is so hypovolemic, they are extremely critical. You just don't have a time to infuse crystalloids in large amount. Then obviously you cannot do that unless you have a colloid. So whatever colloids you have available, that will do. Most of us will probably end up using something called vet starch, like header starch. But I guess you can have a pentastarch, header starch, tetrastarch. These are all polysaccharide. I'm not going to go into more in detail about the risk of colloid, the pros and cons. That's not the point of my talk today. You can have that discussion with Dr. Pressler or Dr. McKenna, unless you have already done that. Yeah, so this is large animal catheters. You have like a 14 gauge, 16 gauge. It's not that you're dealing with a large animal. Sometimes these large bore catheters are useful for small animals to increase the speed of the volume administration that you desire, or it could be even used as tap the chest and establish the drain to evacuate the air or fluids trapped in the chest and so on. So these are just collection of the surgical instrument. Generally, you would need to perform surgery when you want to establish the airway, in other words, tracheostomy, or open chest cardiac massage. What I mean by open chest cardiac massage is that you crack the chest to massage or compress the heart. It's open chest resuscitation that people not generally are willing to perform, but times it's performed, and the prognosis obviously is not zero. Otherwise, people wouldn't bother with that. It's not as good as the closed chest compression resuscitation. Still, when you end up opening chest, you need a surgical instrument, and that needs to be also planned. Again, some of the instruments, when you perform surgery, you would need to prepare for. Drain, or you can just say red rubber tube or suction pump tube there, and different size of the suture materials, and sterile surgical tray would be also needed, and along with a label to easily identify what they are for. Okay, so that's a summary of crash cart and the supplies and equipment that you can have. If you have all those, you would be probably AAHA accredited a clinic that you are running. Most small animal practitioners wouldn't have that level of completeness, but still, I think this can be a good reference for you to prepare whatever you need to prepare for your crash cart. Going into the examples of complications, bradycardia is actually not very uncommon, and particularly in practices where they really are fond of alpha-2 agonists, you're going to see a lot of bradycardia because dexmedetomidine or xylazine, all these alpha-2 agonists will consistently, predictably induce bradycardia. Now, it is a problem if bradycardia accompanies hypertension. By Ohm's law, we know blood pressure is governed by 3 variables. One is heart rate. The other 2 are stroke volume and vascular resistance. And heart rate being lower than optimal, and if the other doesn't change, then we will have a low blood pressure, and that is going to reduce the blood available for all the vital organs. That will lead to increased morbidity. If you do not intervene timely and safely, you will run into higher outcome, cardiac arrest and death. So we want to prevent that from happening. Arbitrarily, I had a 64 dog and 100 for cats, adult cats, but really I think what you should be aware here is it's all relative to what their normal heart rate is, and anything below whatever their baseline heart rate and the change of heart rate lower than 40 or 50%, then the chances are the animal will do poorly on their cardiovascular system, and therefore you need to address that. So what are the causes? Here, anesthetic overdose or increased vagal tone. It could be drug related, opioids and alpha-2 agonists we already talked about, or it could be their breed. Some breeds are known to have a elevated vagal tone, or it could be vagal or parasympathetic stimulation related to surgical manipulation, like visceral organ surgery. Ovarian hysterectomy could be one thing. The eye also, like the enucleation, could also trigger ocular cardiac reflex, bradycardia, or even cardiac arrest. So how can we treat when we see those dangerous bradycardia? I think the rule of thumb is if you know that you have been causing bradycardia due to visceral manipulation or any part of the anatomic part of the body, then you can stop stimulating them and see if the animal will spontaneously resolve back to the normal rate. If that doesn't address it, then fortunately, we have a very effective drug called anticholinergics. It's atropine or glycopyrrolate. Now, if anticholinergics are not working, then a drug like isoproterenol can be used. The only problem with isoproterenol is that it's not just cardiac beta 1 agonist, but it's also peripheral beta 2 agonist. So you're going to run into extensive peripheral vasodilation mediated hypotension. Now, I addressed to you earlier, bradycardia is problematic because they actually reduce cardiac output and blood pressure. Now, in the face of correcting heart rate, bradycardia, and yet you use a drug that can be very effective in correcting heart rate and yet not correcting blood pressure, then you might as well not bother with that. So a lot of times isoproterenol, you run the risk of potentially not really helping blood pressure, despite the fact that you change the heart rate to normal or even tachycardia phase. All right, so the other end of the pendulum, I increased heart rate or tachycardia. The problem with the tachycardia is it's going to increase the myocardial oxygen consumption because contraction is work for the heart. So increased work means increased oxygen need. And if it passes certain point, then it could actually induce more problem. It's only useful to correct the depressed cardiac function by elevating heart rate so much. Cardiac arrhythmia is now going to be started to show, and also another aspect of very, very rapid heart rate is that in order for the heart to pump out the blood, it needs an adequate time for the heart chamber to receive blood. But every time it contracts, there's no receiving of blood by the heart. So if the heart contracts too fast, it's actually pumping out less blood available. So that's another problem with the tachycardia. It actually causes more cardiac depression that way. So what can be examples of tachycardia when the animal is feeling pain due to inadequate anesthetic depth that could trigger the sympathetic stimulation and then increase heart rate? We know drug-induced heart rate increase is also a possibility. Baroreceptor is useful physiologically to have, because when sensing mechanism realize there's a danger of the body to lose blood flow supply to various parts of the organs, what they do is they try to compensate. So let's say there is blood flow reduced or hypertension, then it will trigger also a mechanism to counteract that, and that's hypertension reflex tachycardia. Under general anesthesia, fortunately or unfortunately, we will see respiratory depression a lot, and that's because our drugs are all designed to suppress a lot of the body. The brain activities will be suppressed by anesthetics, but brain governs a lot of other homeostatic activities, including respiration. And when respiration depression is associated with ineffective elimination of the carbon dioxide, we're going to have hypercapnia or hypocarbia, or elevated carbon dioxide in the body trap. And that's going to trigger a sympathetic tone as well, and that leads to tachycardia. We obviously want to understand what causes tachycardia, and address whether by manipulating the anesthetic management, including increased ventilation, respiration rate, by putting them on the mechanical ventilator or manual ventilation support. In the case for hypercarbia or hypercapnia or low blood pressure, we could use different vasoactive agents, including fluids or inotropes. Inadequate anesthetic depth obviously needs to be addressed with appropriate anesthetic administration. But one thing that I would say about anticholinergics, particularly with atropine, they are only lasting 30 minutes to 60 minutes max. And the glycopyrrolate is probably 1 hour and plus minus 30 minutes. And I don't generally treat those tachycardia associated with anticholinergics because I know they are self-limiting, and I can live with that unless I really see all those dire sign of that their myocardial oxygen demand is so bad, as well as the tachycardia mediated cardiac depression is actually worse, then I will intervene. But unless I don't see cyanotic mucous membrane color, prolonged capillary fill time, weak pulse, I don't generally treat them. So blood pressure is almost universally expected during general anesthesia. We know low blood pressure is just given. It's just going to happen. But what would be our tolerable blood pressure? We know they're all hypotensive, but what would be really the number? And that really depends on species. But in small animal, we generally accept mean arterial blood pressure 60 millimeter of mercury would be the lowest cutoff. So anything below that, we consider it needs to be intervened, whatever means that we have to elevate the blood pressure above that. And the premise is that any blood pressure below 60, the animal is going to suffer from tissue perfusion, and that will lead to inadequate organ function and increased likelihood of the animal being irreversible in from their anesthetic state. I say here anesthetic overdose, but even if we do not really overdose anesthesia, let's say animal have mean arterial blood pressure of 70 millimeter of mercury. By definition, that's a hypotension compared to what they would have while they are awake. But under anesthesia, that is not considered hypotension. It's interesting. We do not consider mean arterial blood pressure, for example, 70 millimeter of mercury, as long as they are under anesthetic effect. Okay? So there's a different distinction how we consider what is hypotension and not, whether they're anesthetized or awake. And during surgery, for example, the animal lost quite a bit of the blood, or even if you pay particular attention to control the bleeding, surgery is the process where you are going to cut different vessels, and then they're going to ooze out blood. So it's given that you would have to deal with the blood pressure associated with blood loss, and typically steroids would be a favored choice because they are effective and they are very affordable. If this fluid therapy doesn't address the hypertension, then fortunately you have a very effective cardiovasoactive. Examples include dopamine, dobutamine, ephedrine, phenylephrine, vasopressin. I'm going to talk more about this when we go over the Boxer case, the assignment, because you will have to fill in the tables on these drugs. So let's save it until then. All right, premature ventricular contraction. We all know what that is. It could be caused by acid-base imbalance, hypoxia, hypocapnia, pain, electrolyte disturbance, contusion of the heart, GDVs, and sympathetic imbalance, and drug such as thiopentol. Fortunately, we don't really use thiopentol anymore, at least in North America, and we don't really see that being a problem with propofol, because I feel the drugs you are going to know that epinephrine, vasopressin, those are the mainstays these days to really jumpstart the heart to be used. Now, let's say in the process of resuscitating the animal now goes into fibrillation, and there's no other way other than shocking the animal with the defibrillator to correct that. So you have to have a device, obviously, defibrillator. It can come with all different shape and brands. They all are very effective. This happened to be Hewlett-Packard version. Oh, sorry, Datascope. They all changes their brands a lot, but because one company buys another company and then they rebrand. But anyway, so this one, you see that you'll have to change the energy level depending on the size of the patient. Easy to get confused in the at the time of the resuscitation. You're better off to have a neat, printed out, well laminated table attached to the defibrillator, so that you just use that as your reference source. So the when you shock the patient, you need obviously 2 electrodes. The idea here is that you surround the heart as best as you can, so that entire heart is covered by the electrical current. Obviously, if the animal is small like this, sometimes it's not ideal, but you may even have to do this single side chest. But I think you try to avoid as best as you can to have a placement like this. The goal should be surround the heart, have the ability for entire heart to be well wrapped, and then shocked. So let's say you don't have a defibrillator, then can you do something? Yeah, it's not very effective, but you can obviously try potassium and acetylcholine approach. Let's see. At that point, you have nothing to lose. Some people will call electromechanical dissociation as pulseless electrical activities, but what it is essentially, the heart, continuously, it has an automaticity. So even though the heart doesn't pump or it doesn't actually contract, it can still generate electrical current, and the ECG looks very, very normal. But obviously, the heart is not pumping any blood. There's no cardiac output, and the animal might as well be considered as dead. Okay, so you be aware of those possibilities, and what that tells us that you would need other supporting monitoring device other than ECG, because ECG may fool you thinking that the patient heart is beating well, and yet if you have like a pulse oximeter, it will actually absolutely have a very low oxygen level or blood pressure. Obviously there will be no blood pressure being recorded, so on. This is something called Recover. That's the International Veterinary Critical Care Society version of diagram how you approach the resuscitation care of the animal. So it's available their website. You can print it out, put it well laminate again, and put it next to the crash cart. So there references that I use for the presenting this talk. Okay, so that kind of, let me just stop. Yeah. So that was the last slides. Now, feel free to ask me any questions on today's topic or any other topic.
Hey, Dr.
So,
Lee.
yeah.
When will we be going over the boxer assignments?
We can do it next week, right? Oh no, is that next week? No, that's December, right?
Yeah.
December, yeah.
Okay, so the next time we see each other.
Yeah.
Dr. Lee,
yes.
For the boxer assignment, one of the questions you're asking about like how to dilute a drug that you're giving so that it makes like practical sense. I don't understand what you meant by that.
So like a phenylephrine are drugs that you would use to increase blood pressure. And when the animal's blood pressure is low, let's say you gave too much of aceclomazine. Aceclomazine is a vasodilator and that causes hypertension. So phenylephrine being an alpha-1 agonist, it's very useful to correct that. So on top of the lactate ringer solution that you will have, you're going to have a source of phenylephrine to be infused to the patient. So you are going to prepare phenylephrine infusion set separately. You're not going to add phenylephrine into ARS. That's what I meant by practical sense. You are going to prepare a second set of drug infusion bag that contains phenylephrine. It could be dopamine, it could be dobutamine. And what I mean by practical sense, you're going to use those to prepare. Sorry, I'm a little bit distracted with I've got so many political calls today. I bet you are too. But, yeah, don't forget to vote, ladies and gentlemen, unless you have done that already. But anyway, that website is great because all you need is a weight, the drug rate that you want to, for example, phenylephrine, usually 1 to 2 microgram per kilogram per minute is pretty good dose to correct the hypertension. And then you enter the strength of the concentration based on, are you going to use a 100 ml bag, 250 ml bag, 500 ml bag, or you're going to have a syringe pump using 60 ml syringe in it, and that's pretty much what it is. Thanks, Lindsay, by the way, forwarding that email. Does that answer the question, Natalia?
Okay, so then you're saying like the crystalloid fluids are going to be administered separately from the phenylephrine?
Always.
Okay.
Absolutely. Yeah.
So
you cannot do them both because sometimes you might want have the ability to increase fluid or decrease fluid depending on how the animal responds. So once you add phenylephrine to ARS pack, the phenylephrine also going to increase when you increase ARS, and that is not very practical because phenylephrine is a very potent drug. You don't want to do that. You don't want to mix that. So I have to always have a separate drug delivery for phenylephrine or dopamine. All these very potent drugs. They are very potent drugs. If it is like maybe sugar or dextrose, then fine. Yeah, if you add 50 gram sugar in that, so a little bit of higher sugar, so the blood is going to break it down effectively. But phenylephrine and dopamine, they're just too dangerous to play with. Variation of the fluid rate dependent changes of their rate, it would be just too much of a risk. Well, I hope you enjoy the real life situation next 2 weeks. That'll be fun. I don't want you to, really experience this dire situation, but at least you know how to deal with that when that happens. So I think with that, I'll let you take off for the next sessions. Bye, everyone.